Okay. Let's see. Let's just double check that we're looking good and looking as good as we can, right? And sounding good is something that we can achieve. So let's just double check that and make sure it's happening to the best of our ability. Let's see how we sound. Okay, sound is okay. Okay, sound is okay. So I think because the sound is okay, we're just going to take a quick second and share this on Twitter and see what happens. And then we'll be off to, I guess, what they call the races, if that makes sense. So we'll see how this goes. Okay, let's take a look here. Let's take a look. Where are we at? I'm about to share it on Twitter. Just going to find the live stream. If that makes sense. Share it on Twitter. And just get going. I'm going to copy link. I'm going to get over here. Just going to share it real quick. Okie dokie. All right. Well, I think that everything is appropriately shared and all that good stuff. So we're just going to go ahead and get going and then see what happens. So good afternoon, good evening, good morning, everybody. Welcome to a brand new setup for the UnShrink Me podcast. I have moved rooms. We're in the middle of remodeling some things and reorganizing some things here. So this is my temporary spot. It might be permanent, but I think it's just temporary for the time being. Welcome to this up close and personal episode of UnShrink Me. I am Dr. Patrick Lockwood, but for the purposes of this podcast, I am just Patrick. So please don't sue me. This is not clinical advice for you as an individual, your family, etc. I am just here speaking on behalf of the people I've worked with, the people I know, the people I've trained, my colleagues, my interns. I'm trying to share the experiences I've had as a professor, as a clinician, as a consultant, as a supervisor, to do two and only two things. Number one, to give people some hope about what will help them with their mental health services. And number two, to criticize either bad or flawed ideas so that you can have a more realistic idea of what works when you're reaching out for mental health services. So my goal with the UnShrink Me podcast, if you're brand new to this, is just to help people who are consuming mental health services at whatever scale, family therapy, couples therapy, individual therapy, treatment, rehab, counseling, coaching, whatever. I just want you to get the most out of those services. So all the opinions that I share here are non-clinical. I am not your therapist. I am not your consultant. I am definitely not your professor. I'm just a dude with a microphone and a jacket who gets to talk about things that I've experienced, that I understand, that I believe. And so I hope this is helpful in some way, shape, or form. This is dedicated to you, the consumers of services. Sometimes my colleagues come out and chat, and that's always a good time. So be looking for them in the chat replay if you watch this after the fact. And today we have some fun things to talk about. We're going to talk about understanding and empathy. We're going to talk about validation and why validation matters. And I want to spend some time talking about something that's kind of complicated that might make it somewhat easier to understand how therapy works and does not work. And we're going to talk about so-called clinical intuition. And as always, this podcast is not N-O-T, not sponsored by Celsius. However, I love this stuff. It's awesome. It makes my life better. And it tastes good. So, thanks so much to everyone who comes out. Please like, share, and subscribe. Darren McGee is here. Good to see you, Darren. So happy to hear you're here and see that you're here. So, today there are a number of important topics, but as always, I like to go to Twitter. And for those of you who don't know, if you've never listened to this podcast before, my handle on Twitter is Alobha Patrick, at ALOBHAPATRICK. So at Alobha Patrick, and that's where I'll be tweeting from, live tweeting during this podcast. Because what I like to do is I like to find posts and tweets on Twitter that relate to mental health topics, and we can talk about them and unpack them, me, myself, and also with the people in the chat. So as always, I like to start with a bit of a softball so that we can warm ourselves up and kind of ease our way into the discussion for the day. Okay. So today's kind of softball warm-up post is going to be brought to you by someone named Jonathan Shedler. If you don't follow him on Twitter, I really hope that you do, because he's, I think, a helpful voice in the ecosystem of therapists. So let me retweet this right now. Okie dokie. Okay. So about 6 days ago, about a week ago, Jonathan Shedler, his handle, by the way, is at JONATHANSHEDLER. So his handle is Jonathan Shedler. And here's what he said about 6 days ago. He said, therapy brand or modality counts for shit. Within every legitimate modality, there are skilled practitioners, incompetent practitioners, and downright destructive practitioners. If you average across them all, you get garbage. That's why, in parentheses, one reason why, outcome research shows equivalent results for different therapy brands. That's the dodo bird effect. And as flawed as the outcome research is, it still shows significant benefits. While we're on the topic, research also shows that meaningful psychological change in psychotherapy begins on average at around 6 months and continues on average for 1 to 2 years. Most therapy outcome studies are over before meaningful psychological change even begins. And he posted an article that I think you should all read if you follow him. So I hope you follow Jonathan. I hope you read his article, because I think he's onto something. So here's what I said, just in reposting it. Every word of this: effective therapy is about having ethical and well-trained providers. So I want to touch on 3 very simple things that Jonathan said that are deceptively simple. The first thing he said, which is a little provocative, is that therapy brand counts for shit. So if you're out there and you're currently considering getting therapy of some kind for some problem, maybe you have a lot of trauma and you're looking to work on your PTSD. Maybe you have what you believe is depression or a substance use problem. It's very tempting to find a brand of therapy because it comes with some sense of like research-backed guarantee. So not that this is my hobby horse, just one example is there's a big fad that's been, worsening for the last couple of years, which is EMDR, eye movement desensitization reprocessing therapy. So EMDR is a type of therapy specifically designed by Shapiro to address, trauma, PTSD. And there are some unique differences for what EMDR is, but it is mostly just exposure therapy. There are common factors among all the clinical interventions we have, all the therapies. And EMDR works by doing processing and exposure work, just like all trauma therapies, by the way, are exposure therapies, in case you didn't know that. So exposure works great. It's very hard. It's very, very hard to do any kind of exposure therapy, whether it's EMDR or old school graduated exposure therapy or CPT or whatever. All I will tell you all is that the brand in and of itself really doesn't mean a whole lot to me as a clinical supervisor or as a professor. And the reason's because you can have full and deep understanding of what a modality actually is and have no clue how to use it, number one. Or number two, no clue how to manage your stuff as a therapist. Manage your countertransfers, your reactions, your biases. So you can be the most skilled at doing skills with people, but that doesn't mean you understand how you react as a professional. So Jonathan's correct that the brand doesn't mean anything, right? The brand doesn't mean shit, as he said. He said there are skilled practitioners, incompetent practitioners, and downright destructive practitioners. So the other thing he said is, as flawed as the outcome research is, it still shows that it helps. So I want everyone to understand there are a great many naysayers online. People who think therapy is just pseudoscience. People who think therapy is only harmful. And I'm here to tell you that that's absolute garbage. There are definitely some therapists who hurt people who are unaware that they're hurting people. There definitely are some therapists who are inconsistently harmful and inconsistently helpful. And then there are some therapists who are mostly helpful, right? And so it's really important for everyone to understand, please hear me very clearly, that there is no such thing as a perfect or mostly good therapist. And the reason for that is because we're all just people. And because we're all just people, it's quite literally impossible to be consistently, perfectly a good person, right? We can do our best to improve over time as clinicians with you and try to help you more and more. But the idea that we are somehow magically more evolved and perfectly self-aware such that we don't cause harm ever is never going to happen. So it's about repair. It's rupture and repair. So please be aware that harm does happen in therapy from time to time, even with the best practitioners, just so we're clear. But there are a lot of mediocre practitioners out there as well. But therapy still helps. There's a lot of people that get help from good therapists or even okay therapists. So please don't give up hope on therapy if you really actually need it. And the third thing I want to pick on in his tweet that I think is worth discussing is that the meaningful change topic. So he said, approximately speaking, meaningful change starts to happen around 6 months. And, it can happen for upwards of 2 years. So how we define meaningful change will dictate what that means, obviously. But here's what I want to do to break it down very simply. Doing super deep, super challenging work for more than 6 months will burn anybody out. So I hope that everyone understands that there is no obligation to be deeply searching at all times. That will exhaust you, and that's not usually helpful for most people. In fact, the motivational interviewing research is perfectly clear that trying to do a bunch of deep, profound work for like 6 continuous months will burn people out. So what you want to consider is how long you need to be in therapy, and you should have that discussion openly with your professional to figure out what is reasonable and how much change you can handle over what periods of time. And it might evolve. It might actually change. The type of change you're looking to make might change with new information and insight. So my takeaway from this is, please have a very flexible and open attitude towards change, because it's not linear. It's almost never linear. And you might discover things about yourself or just in the context of your therapy relationship that alter how much you really think you need to do. Some people I've worked with in different settings felt like they had to keep doing therapy for a long time. And God bless, if that's really helpful for you, awesome. Some people realize that they've kind of hit a plateau of sorts and they're okay with where they're at, and they might come back and work on some other things later. I don't think there's a one-size-fits-all and perfectly objective way to look at this. I think it's a very individual and subjective thing, even across diagnoses. So thank you, Jonathan, for this kind of grist for the mill here. And I hope everyone understands that therapy is challenging and it's very individual, and there really is no perfect or reliable way to, take care of everybody in exactly the same way, because it's about the individual practitioner and how they're built, and the individual patient and what their needs and goals are. So I hope that all makes sense for everybody. So thank you, Jonathan, as always. Let's talk about the concept of validation next, shall we? Because I think a lot of people in therapy have a very confused notion. I think a lot of therapists, unfortunately, have a very confused set of beliefs around what it means to validate somebody or to care about validation. So let me retweet this post real quick from one of my online friends, and we can talk about it. Okay. So this next person I'm retweeting is someone I don't think I've talked a lot about at all on the podcast. Okay. So one of my online friends is this person named at Feisty Kitty, Kitty Pie, P-I-E, at Feisty Kitty Pie. And yesterday she said something really, he, I have no clue, but this person said something somewhat controversial, which I think is really, really helpful for us to talk about when it comes to therapy. Because therapy is, again, very complicated, and I never want people to feel misled or sold a bill of goods. So this component, this concept of therapy is really worth thinking twice about, and it's validation. So here's what they said. And I quote, "I see that some therapists use validate as a short form for colluding with patients' perspectives of things that are distorted by their use of defenses. And some therapists brag about never validating and how they don't care if some patients get offended." Okay, so Feisty Kitty Pie is talking about online therapists. So for those of you who don't know, for those of you who are just listening to this podcast and don't spend time on Twitter or other similar social media platforms, there are various groups and clusters of clinicians online, and we are quite the handful, all of us. All of us have unique and colorful personalities and spicy takes and opinions on things, and it's fun because most of us are there in good faith, just trying to, talk things out and joke around with each other. Some people are not. Some people are malicious, and I try not to be. Sometimes I don't do my best, and I'll admit that. But I like this person because we get to have fun, talk about cats, talk about therapy. And this is one of those examples of a really cool, just serendipitous post that's really worth talking about. So online therapists, some of us are the worst people on the planet. So therapists online will have essentially, unfortunately, one of two opinions about validation. Some therapists are like, validation's terrible, it's enabling people, it's colluding with them, right? And for those of you who don't know, when a therapist colludes with the patient, what that means is we work in such a way that we are not actually part of a change process, we're part of a staying the same process, right? So like, if you use the defense of intellectualizing against your emotions, like you don't want to deal with your feelings, so you think about them, right? We might have a cerebral conversation with you in therapy as opposed to just sticking to what the feelings are like for you and processing the feelings, right? And just sitting with them, even taking a pause and just sitting with them. So that's colluding when we choose to, this is an example of colluding where we don't sit with the feelings and just sit there and tolerate them together. We actually just talk about them and think about them. That can be colluding. And so some people try to engage in validation in therapy by just talking excessively and thinking out loud excessively, right? That's a type of validating that happens in therapy, and some therapy bros in particular are like, I'm not like that. These woke idiots, all they do is agree with you and think out loud with you and make you feel like you're right. They agree with your opinions, and that's colluding, and that's stupid. And then some therapists are like really, super affirmative, to use a political word, where all they really do is they just try to, like, quote unquote, make you feel good, make you feel empowered by agreeing with your perspective, like I was just talking about with the anti-woke therapists. So something that's really important is these two extremes exist, where people are genuinely overly validating in a way that's not in that Carl Rogers sense of things. And then some people are like intentionally too stoic and trying to withhold from patients because they don't want them to feel enabled or colluded with. Both extremes do exist in therapy. And in the online therapy world, both types of therapists have opinions on this. And here's what I would say. It's really important for you, the patient, to understand that you are experiencing something and the therapist sitting across from you can't really fully know what you're experiencing. And I'm going to say more about this when we switch gears to the empathy discussion, but we're not there yet. But I just want to plant this flag that we're going to come back to it. But I want you to understand that we can never fully know what you're going through. So what we will try to do as therapists, one skill we have is the skill of validation. And validation is not just saying, I think you're correct, or what you're going through makes sense, right? Normalizing, for instance, can be a type of validation. But there's also trying to help people feel understood. So we do things like rephrasing or even reframing sometimes. So we might rephrase. We might say the same thing you just said in our own words to see if we understood you correctly. And that can be validating. And that in and of itself isn't the same thing as saying, I agree that your perspective on whatever happened makes sense or is correct. So what I want everyone to understand is that validation is a really complicated thing. And really, the hardest part of validation in therapy is knowing not just when to do it and in what way, but also what's your goal with validation as a therapist, right? So when I do supervision with clinicians, I'm not training them to just validate, rephrase, summarize, paraphrase, normalize just to make the patient feel good. I think making the patient feel good is often a trap, right? It's a question of what is this person's goal, right? So if this person has a goal to just tolerate their feelings more, that's different than their goal of changing a behavior, for instance, right? So in those two examples I just gave, maybe for the purpose of tolerating the feelings, you might normalize something and it will help them have some outside ego to tolerate those feelings. But in some people's cases, that's counterproductive and even destructive because you might have feelings that are based upon completely delusional or even traumatized experiences. If you're having a flashback and that causes you to rage out at your spouse, then no, that's not normal. That's not something you can quote unquote normalize, right? Because most people do not rage out at their spouse, number one. But number two, it's not normal to allow your trauma to hijack your romantic relationship. It's our job ethically as clinicians to help people find more productive and empowering ways of dealing with your trauma in that situation other than yelling at your spouse. So for me, validation is not a simple thing. Validation is a complicated thing based upon the patient's problem, their personality, their culture, the therapist's countertransference, their culture, their beliefs. So validation is not this simple thing. And a lot of therapists will be validating things that serve the therapist that don't actually serve the patient, right? So if you're doing a lot of validating as a therapist, are you trying to make the patient feel better so you feel better? If you're doing a lot of validating as a therapist, are you trying to make yourself feel smart or like a good person when you're talking to the patient? That happens all the time. That's a countertransference problem. Yeah, Darren says, why not just acknowledge and explore? Exactly. So one of the alternatives to validating is to acknowledge what the person said and try to explore what they said as opposed to validating what they said. Because sometimes validating is enabling. Sometimes it's not, right? And so it's a very individual thing. But all these culture warriors, the woke types and the anti-woke types, have these really stupid takes about like, I come from so much shame, all you should do is validate me, which is bullshit. Or I think there's so many pathetic people out there that all we do is make them soft by validating them, which is also bullshit. You know? It's bullshit. So, yeah, I think, Darren, many times we can acknowledge what someone said, even, rephrase it or parrot it back to them in some way that's meaningful to both parties, and try to explore it as opposed to just saying or normalizing it, right? Normalizing is a very effective skill, but it doesn't have to be done all the time, right? Any therapy skill should not be done all the time. It's a question of what does this particular unique person need given their unique circumstances, and what do I, the clinician, understand about this person and how I react to them with my countertransference and my issues as a therapist, right? And once you do that math, then you can determine how useful it really is to engage in validating of various kinds and to various degrees too. Because you can minimally validate without going overboard and saying, yes, queen, you're the best, or some stupid shit like that. You can just be like, I hear you. That makes sense to me without like really digging into it emotionally, right? So validation is a spectrum. We can call it validation on the spectrum as opposed to love on the spectrum. So thank you, Feisty Kitty Pie. And then just something else that I want to double down on. I'm going to retweet this person real quick. There's a person on Twitter called Jordanticus at JORDANTICUS. And they're literally talking about the exact same post that I am from Feisty Kitty Pie. So I just want to give them a shout out as well. So in response to Feisty Kitty Pie, Jordanticus said, "We should always reflect on what we personally, the therapists, are getting out of each session with each individual patient. Praise and admiration, or dominance and control, or feeling useful and valuable, etc. And I don't mean to be on the lookout for it. I mean that it's already there. Sometimes it tells us a bit about the patient, but it is always telling us about ourselves. Be in your own therapy and have good supervision." And all I would like to say is amen, Jordan. I mean, I think for patients and families of patients, I want you to understand that your therapist is a person. Your therapist is a regular person. And because your therapist is a regular person, in just a perfectly normal way, your therapist is getting something out of whatever they're doing with you in session. So I want to say that again because a lot of people have this mistaken belief that being a therapist means you're so special, so smart, so self-aware, or so evolved that you're neutral, that you're quote unquote not getting something out of being in therapy with somebody as a professional. Therapists are always getting something out of their therapeutic work with the patient. The question specifically is, in this particular therapeutic relationship, what specifically do I get out of working with this person when I do these interventions? That's called managing and monitoring countertransference, right? And so what Jordan is pointing to, just to give some examples again, praise and admiration, or dominance and control, or feeling useful and valuable. So three different things, three different sets of things, motivations that the therapist has. And I don't tell everyone this so that you have to worry about what your therapist is getting out of therapy. I just want everyone who is in rehab, in treatment, in counseling, Christian counseling, couples counseling, individual therapy, group therapy, family therapy, the person you're sitting across from who is a professional, who has a degree or set of degrees, who has a license in many cases, that person is still a regular person that has needs and wishes and biases and baggage. And all of those things, their wishes, their needs, their biases and baggage are being played out in therapy with you. Part of being a really good therapist is understanding how to work yourself as a therapist to help this person that we call the patient. So using the relationship is what expert therapists do. It's not mastery of skills. Skills are important for sure. Reframing, paraphrasing, normalizing, highlighting discrepancies. All these skills are great and very important, and I make sure my interns understand how to use them. But learning how to better use the relationship between the two people is where expertise starts to develop. And that's hard to do because it requires being aware of a lot of things in the moment in kind of like a flow state, and that's hard to do. So it's hard to do really good therapy because it means really being aware of what the patient's wishes, needs, and their patient's transference is, but being aware of your countertransference, your wishes, your needs, your baggage as a therapist. That's really hard for clinicians to do because taking a long look in the mirror as a therapist is not super comfortable. A lot of people come into therapy because they want to avoid their stuff or have an intellectualized solution to their stuff to learn these skills to deal with their stuff. but there's no amount of diaphragmatic breathing that will make you less narcissistic. There's no amount of grounding that will make your desire to feel powerful or special go away. Most therapists have a hard time accepting themselves and their baggage. And I want every consumer of therapy to hear this. Therapists are regular people, and I don't mean this in a disparaging way. I'm actually very optimistic about this. Because every therapist has some need for praise and admiration, as Jordan said. Every therapist has some need for dominance or control. Every therapist has some need to feel useful and valuable. And it's the art of recognizing your needs as a therapist, your baggage, your gifts, your strengths, your weaknesses, and trying to use them to help the person across from you in an ethical and boundaried way. That is the art of really good therapy. And plenty of people care enough about themselves and their patients to try to be aware of those things I just listed. So I want everyone to understand that the art of good therapy is complicated, and it takes time to know how to use the relationship effectively to help people, okay? So I hope that makes sense to everyone. Okay, next, I'm going to do a quick, nice and easy one real quick. Okay, so this next post is a little bit controversial. So someone I've discussed here on the podcast before is named Dr. Roger McFillin. And his handle is at DRMCFILLIN at Dr. McFillin. So 3 days ago, Dr. McFillin said, "Stop acting like DSM diagnoses are real." And here's what I have to say about that. Diagnoses are constructs, and they're metaphors, they're euphemisms, and sometimes the diagnoses are very real, and you'd be a fool to not acknowledge they exist. So like, bipolar 1 is a real thing, and pretending that it's not a real thing will kill people. So let's be super clear that some of these illnesses are very, very real, and pretending like they're not will kill people. So bipolar 1 is an easy example. Severe substance use disorders we call addictions are very real and they kill people. Severe eating disorders are very real and they kill people. Anorexia kills people all the time. Severe OCD has a very high suicide rate. So I don't know what to tell you, Dr. McFillin, but my hope for everyone is if you are really, really badly struggling, I hope you get the help you need, because whatever you're struggling with, especially if it's diagnosable, has solutions. The solutions are not perfect. They don't fix you. They don't cure you. You're not broken. You're not a ham. You don't need to be cured. So genuinely speaking, diagnoses are real in many cases. Now, once you get to the more mild and moderate versions of most diagnoses, they're not statistically very reliable conditions. The other problem is some people have multiple diagnoses at once, and that muddies the picture, statistically speaking. So the research doesn't look super clear. So some diagnoses are not real. I was just on a podcast yesterday with Ryan Rogers talking about this, or 2 days ago. Shout out to Ryan. And the Reality Therapy podcast. But ODD, oppositional defiant disorder, is absolutely not a real condition. It's a bad parenting problem, right? But the idea that severe OCD or PTSD or bipolar 1 or severe substance use we call an addiction is not a real thing is absurd. I don't know about you, but if you've ever seen Alzheimer's dementia or neurocognitive disorder, it's a real thing, and it's a tragic thing. So the idea that some diagnoses are bullshit, therefore all of them are, is absolute nonsense, Dr. McFillin. And if you're out there and your diagnostic label gives you some comfort and some path forward, then that's awesome, and that's all it's meant to do, because it helps you make sense of your experience. However, on the other side of this conversation, let me say this very clearly. I hope you do not identify with your diagnosis. Again, I hope you do not identify with your diagnosis. And the reason for that is your diagnosis is not your personality. Your diagnosis is not your be-all, end-all of your existence. You know, in almost zero cases is your diagnosis the most important thing about you. Even with terminal illnesses like Huntington's disease or Parkinson's disease or Alzheimer's neurocognitive disorder, it's still not the most important thing about you, even though it's a big deal. You're still a person with worth and value despite this label that explains your symptoms. So it's really important. It's really, really important. I want everyone to hear this loud and clear that diagnoses are sometimes very real and very reliable constructs. In some cases, for other people, they are closer to a cold. And why would you identify with the cold, right? So like mild and moderate depression, usually closer to a cold or a flu. It's a set of symptoms that are related to an underlying illness that's not the cold itself, right? But it's still something worth considering. The metaphor, the construct is useful. So please don't identify with your label. Your label is secondary or tertiary in your identity, you know? Excuse me. So your identity is complicated. Your identity is very complicated, and making your diagnostic label the be-all, end-all of your identity is not a good idea to be a well-adjusted person and survive in the world. I think most people have a better quality of life when they recognize that whatever their diagnostic issues are or their personality differences are just one small piece of the bigger picture of who they are as a person. So on the one hand, yes, certain diagnoses are very real and very reliable and very treatable, thank God. Some diagnoses are terminal and not treatable, just manageable. Some diagnoses, because they're very heterogeneous, are not even really valid and reliable constructs. You know, so when I was on the podcast with Ryan Rogers the other day on the Reality Therapy podcast, I said, you know, some should definitely be removed from the book altogether, the DSM altogether. But no, Dr. McFillin, diagnoses are real. They're certainly very, very real. What are you fucking saying? What's wrong with you? It's more complicated than that. Why are you oversimplifying it? I certainly wish they weren't real, but they are certainly real. Okay? So, I don't know. All right. And so the last big post I want to talk about today, which I was discussing yesterday, is, you know, a lot of people are afraid to start therapy because it's a very, like, ambiguous thing. It's this amorphous thing. It's this confusing, hard to understand thing. Like, what is therapy? What am I actually doing? It's a relationship. I'm paying for a relationship. What is this? And so I want people to understand very clearly what therapy is and what it is not, and what therapists do and do not do. Because I think if you understand what it is and what it is not, you know how to get better therapy from people that you're currently working with or seeking out. So I'm not telling you what you should be doing as the patient or family member of a patient. I'm telling you kind of what I try to teach my grad students. I'm telling you what I try to kind of encourage in my supervisees as a clinical supervisor. But I'm not giving you an individual or your family specific advice, just so we're clear. And I want to make things less ambiguous so that it's easier to understand, so that you can get the most out of whatever clinical work you're trying to, you know, seek out right now. And I know it's really scary and confusing for some people. Many of you feel probably very ashamed about wanting help or needing help. There are lots of solutions for that. And I don't ever want people to be turned away from therapy. So in the spirit of making sure people don't get turned away from therapy, I want to make sure you understand what it simply put could be and is not, right? So that's the spirit with which I'm about to discuss this post. Okay. So let me retweet this real quick. Okay. So yesterday, one of the clinicians I follow online, her name is Franny Fanny, her handle is at proud_Penelope. She said, I think therapy gets devalued in these ways by people in the field and outside of it, because the skill involved is often invisible to the naked eye. If the average person was a fly on the wall for a portion of a therapy session with a skilled therapist, they may not see what was happening in the room. So I'm not going to read her whole thread because it's a very comprehensive thread, but I think if you're on Twitter and you're looking to have some perspective on what therapy is, Proud Penelope, or her name is Franny Fanny, is a great follow. I hope you follow her as well. In fact, I hope you follow everyone I've talked about today because they're all rad people. So here's what I said in response to her point about things being invisible and hard to understand and being devalued. Here's what I said yesterday in response to her as I quoted her. I said, clinical intuition is not magic. Differentiating content, transference, and countertransference is complicated but trainable. Learning how to listen to yourself and the patient is the art of therapy. The harder part of therapy is having a spine. And what I mean by that is recognizing how screwed up you, the therapist, royal you, all of us are, as a person who happens to be a therapist. And then not letting that affect your work. That takes courage. So one thing I want to say very straightforwardly is to be a really, really good therapist, to be a higher quality, effective therapist, you have to have a lot of courage. Because it takes a lot of courage to really reckon with what I said earlier, which is to reckon with the idea that you are a regular person, that you have blind spots, that you have baggage that will show up in your professional relationship with the patient. So step one, accepting and acknowledging just how screwed up you are as a clinician, as a person, at the same time. Both. Step two of that is having the courage to try to look for the ways in which your baggage and your stuff shows up in therapy. Right? Darren just said in the chat, that's why therapists go to therapy. Exactly. But it takes a lot of courage to do step one and step two. So step one is just to recognize that I'm a regular person as a professional. And because I'm a regular person, I have baggage, I have bias, I have unmet needs that probably drove me to therapy in the first place. And maybe I would quit if I figured out what those were. That's just me. But number two, that if I pay extra attention to what I do as the therapist in the room, my reactions, how my baggage and my needs show up in the room, I might be able to help the patient better by using the relationship more effectively. And just doing step one and step two, we haven't even talked about step 5, 7, 10. We're just talking about step one and step two. That takes immense courage. Because the average person walking around on the planet lives gloriously in denial about all of their shortcomings. Because otherwise we'd lose our minds, you know? So as Darren said, that's why therapists go to therapy. I hope that if you're out there and you're in the profession, if you don't at least have a consulting supervisor or an actual supervisor or a therapist, I hope that you get some feedback from colleagues from time to time about your biases. Because the more we help each other be accountable, the better work we'll do. That's one of the reasons why I stay in the field as a supervisor. Because I know for a fact that I have just as many flaws and needs and desires as any other person. And if I stay as a supervisor, I'll have to be reminded of what that is and see how it plays out with my supervisees so that I don't hurt them, but I help them, right? So doing the work always benefits the therapist, as Jordan said, as Jordanticus said, number one. But number two, to do therapy well requires a lot of courage. And if you're out there in the profession and you go to therapy to make sure you're on top of your stuff and to manage your countertransference better, I'm so proud of you and I'm so grateful that you do that. I just wish more people had some sources and systems of accountability, because those that think they're fine are the problem, in my opinion. The therapists that think I figured it all out, I'm good, are the problem. It takes immense courage to look in the mirror and go, I'm a regular person as well. I have these needs to feel special, to feel important, to feel powerful, to feel admired, to feel attractive, to see myself as deep and profound when in reality I'm shallow, or vice versa. Some therapists wish they were more histrionic and shallow because they're tired of being burdened by the profundity of their mind. Whatever it is, it doesn't matter. It's all normal. And so I think recognizing how messed up we are as people, as regular people, takes immense courage, number one. And number two, it takes even more courage to do something about it, both in the room as a therapist, but outside of it, to take care of yourself and to improve your skills. But just to normalize and make sure people who are taking this in some kind of cynical way, I'm very optimistic, because learning how to pay attention to transference, pay attention to content, and pay attention to countertransference is very doable. I have successfully done this with supervisees for years. I get to see it be taught in graduate schools like the one I teach at. It's not magic. It's complicated because people are complicated. And if we respect people, we see how complicated they are. That doesn't mean it's magic. That doesn't mean that it's impossible to understand. So to Franny Fanny, what I said was not in the spirit of trying to be confrontational, just we don't want to mystify things that don't need to be mystical, because therapy is not mystical. Therapy is a professional relationship. That's all it is. It's a professional relationship. In my opinion, it's no different in some ways than being a personal trainer. Because a good personal trainer is somebody who knows how to leverage their personality and their relationship to help their personal training client. That involves skills, that involves paying attention to patterns, tracking data, and the thing that good therapists do, that know how to do, is they know how to pay attention to their stuff, their countertransference. And that's really hard, by the way. And I hope that everyone understands that really good therapy is hard. It takes time. Like Jonathan Shedler said, you're kind of just getting to know the person after 6 months and deep in the middle of the big change process. So I hope if you're out there and you don't like your therapist, or you're not sure if your therapist is helping you, I hope you have some patience for yourself and for your therapist, because they might not be fully aware of what's happening. And I hope that if you're out there and you're a therapist, if you're a counselor, if you're a coach, and you need help recognizing your stuff and finding supervision, please hit me up. Show up in my DMs on Twitter. They're open. We can talk about it. We can figure out a way to get you a supervisor in your area. Like, everybody, the beautiful thing about therapy is if you learn to understand yourself better as a therapist, your biases, your baggage, your countertransference, you can help the patients better. You can have better boundaries. You can help people quicker, even in some cases. So, clinical intuition is not magic. What good therapists do, by the way, is not magic. If you feel like what you're doing is magical, you might not be in therapy. You might be with a guru. And gurus are not therapists. Gurus are Svengalis. They're magicians. So if you feel like magic is happening to you, it's probably not therapy. If you feel like you're having a real relationship, that's closer to therapy. You know, that's just like a quick and dirty line in the sand, if that makes sense to everyone. So I hope that makes sense. I hope you all understand the spirit with which I said that. And I hope that if you're out there and you're a counselor, a coach, a pastor, whatever, I hope that you find either a therapist or a consultant or a supervisor that can help you recognize your stuff and be on top of it. At least have a colleague that will help you stay accountable to your baggage, your countertransference, your bias, your needs, good, bad, or otherwise. Okay? I really hope that makes sense because everybody can do it. Very few people are in the profession who are so, crazy and out of control that they can't do it. Most people can, thank goodness. And finally, we're going to end with a simple one. We're going to end with a super simple one. Okay. Just going to repost this real quick. Okay. All right. So this person, who I don't think I've ever interacted with before, just seems to be quoting Irvin Yalom. This was on March 21st, her original post. I came across it earlier this week. So here's the original post that Dr. Linda Berman said. She said, and I quote, "To care of another individual means to know and to experience the other as fully as possible." Irvin D. Yalom. So she was saying basically, to really understand and care for somebody means to experience them as fully as possible. And here's what I said 6 days ago. To know and experience someone as fully as possible is idealistic nonsense. Humans are not designed to actually understand another person. We are designed to empathize, which is quite literally fantasy and projection, per the neuroscience of empathy. So I want to say this super loud and clear so everyone has super realistic expectations for therapy. Just again, therapists do not understand you. Therapists attempt to understand you. We literally cannot understand you as a patient. What we can try to understand in glimpses, in themes and patterns, is what you tell us and the patterns of behavior and information that show up in our mind. So therapists try to professionally use empathy to make sense of what you're going through. Whereas the average person walking around all day just kind of reactionarily uses empathy to relate to each other. What therapists do is they try to pay attention to context, patterns, themes, and use their empathy in the moment to make sense of countertransference and what's happening with the patient to make sense of what's happening with you. So all that's a very complicated way of saying therapists learn how to pay professional attention and try to be aware of their stuff. But the more we're aware of our stuff, the less we're actually trying to understand you. We're trying to understand us in therapy. So it's idealistic, this idea that therapists will understand you. I know a lot of people feel better when they quote unquote feel understood. And I'm not trying to say avoid that. It's awesome when we feel understood by people. It's part of what makes life so awesome. So in therapy, it's totally great if you have moments of feeling understood. I don't want that to stop. What I want everyone to understand on the other hand, is that your therapist does not perfectly or exquisitely understand you. Your therapist has some semblance of understanding you, but it's like a mirror. A mirror is not a perfect representation of what you look like. A mirror is a representation of what you look like, but it's not a perfect representation. Even the best glass is not perfect. So what I want everyone to understand is that you are never going to be perfectly understood. To, use a Donald Winnicott phrase, hopefully you have a good enough relationship where you feel understood in a good enough way with your therapist. So I hope that makes sense for everyone. I hope all this makes sense. Again, I want to make sure that everything I say here is just in the spirit of having realistic approaches to therapy. Because when you have a realistic set of expectations for doing therapy, you're likely going to get the most out of your therapy. When you have outsized expectations, you're probably going to be very disappointed. And if your therapist is co-signing unrealistic expectations, that means you have a shitty therapist. So the whole spirit of the UnShrink Me podcast is just to destroy unrealistic expectations so you can have the best possible outcome with your clinicians. So all I want today is for you to realize how much therapists are regular people who want to help, usually, who want to understand. And there's more we can do to be better therapists. Also, realistic expectations is what it means to really care about somebody. Unrealistic expectations is where wishes and fantasies live. And that's what we should explore as professionals if our patients have unrealistic wishes and fantasies, which is understandable because a lot of people are suffering and they want their suffering to end, So I hope this has all been understandable and made sense to everyone. I really appreciate everyone who came out to watch. We've had a lot of people come watch, but only a couple people chat. So thank you for those of you like Darren who came to chat today. Really appreciate that. I hope that if you found something helpful, provocative, or interesting today, that you like, share, and subscribe. My podcast is on my YouTube channel, The Psychology Checkup. This podcast is called the UnShrink Me podcast, and we are here to do two things and only two things, which is to criticize unrealistic ideas, number one, so that you get the most out of your therapist, and number two, provide hope, provide realistic expectations and hope that things can actually get better because they can get better. We can all get better. So, I hope this has made sense. Please like, share, and subscribe. If you have any questions, please follow me on Twitter or at me or come into my DMs on Twitter. Again, my Twitter handle is at AlobhaPatrick, at ALOBHAPATRICK. And as always, I like to thanks Club Exile for promoting me. Thank you so much for doing that. Really appreciate it. I hope that you understand. I also like to have fun. So as always, I like to end this podcast with a joke. Club Exile, please DM me on Twitter and I'll come on your podcast and we can come talk about it. So thank you all for being here and we'll talk soon. So here is my joke for today's podcast. I once worked with a trauma patient, someone who had a lot of shame and trauma and embarrassment. And this individual came in because they thought they had PTSD. And so we sat down and we talked. And this person had this very strong reaction to numbers. And imagine how impaired their life was because they always had some kind of like visceral reaction when people start talking about numbers, time, money, all these things. I thought maybe they had like a fear of money or fear of success or something. But here's what they told me. So they have this extremely phobic reaction to numbers. Like they have panic and sweats and rage and fear and stuff every time someone talks about numbers. So their life was hell. So in the first session, they were telling me this story about how, what they thought the cause was of this fear of numbers. So here's what they said. They said that when they were in like second or third grade, they had a math teacher who was very mean, basically. This math teacher was kind of a dick and an asshole, and they were trying to they didn't like their job, I guess, as a math teacher. I don't know. Anyways, so my patient was in class and struggling with math. They weren't like naturally gifted at math or whatever. And they were struggling and they tried to ask the math teacher for help, but basically the math teacher embarrassed them and shamed them in front of the entire class. And I think that's where this sensitivity to numbers showed up. And, after telling me the story, we're getting down to the end of the first session. And they look at me and they go, Dr. Lockwood, what do you think? Do you think that this is like PTSD? and all this stuff. Like, what do you think? And I said, well, it all adds up to me. All right. I hope you all have a great rest of your weekend. I hope you have really good food. I hope you have really good sex. I hope you have really good friends and family relationships. I hope you take really good care of yourselves. Eat, sleep, exercise. Do the things that make your life better. It can get better progressively day after